Hello, everybody in podcast land. I'm Dr. Ted Thachenkary, and this is MD Roundtable, a podcast about collaborating and learning from other healthcare professionals from all over the globe. We are all so much more connected due to technology. We have so much to learn from each other. Thanks for joining us today at MD Roundtable. This is a very special episode as we are featuring Dr. Jovenel Cherenfant, who is the Medical Director of Surgery for Dyer, Hammond, and Munster with the Franciscan Physician Network. Dr. Cherenfant specializes in general, endocrine, and oncologic surgery. Jovi is also a dear friend of mine, and he has been joining me on our medical mission trips to Ghana, West Africa, since 2010 with Anidaso Health. He is definitely one of the most humble people I know. Welcome to MD Roundtable, Dr. Cherenfant.
Thanks for inviting me, Ted. A pleasure of mine. The pleasure is all mine.
Of course, Jovi. Well, let's get started. Why don't we talk about where you grew up, Jovi, for the audience?
By my accent, you can tell I'm not from here. Huh? I was born in Haiti, raised there, and I came to America to finish high school. My parents live in Boston, so I ended up staying in Boston. So it's Haiti is home. I always thought, would come to America, get your education, and then go back home. But let me see, 25 years later, I'm still here.
Yeah.
So this is my new home.
Right. How old were you, Jovi, when you
15
came to the U.S.? Okay.
15 going on to 16, came in to finish high school. Yeah.
Yeah. What was that like growing up in Haiti?
Oh, man, I had a great childhood, man. Haiti is home for me. It's my culture. It's everything. One of the poorest countries in the world, but I was blessed enough that my family could provide me with the basic things in life. But despite the poverty in Haiti and everything else, there's so much culture, such richness in everything else that I never really got to experience Haiti the way most people do. Fortunately for me, when I look back and look at Haiti, wow. I have more of an understanding of Haiti now as an adult than I did. Growing up, it was one of the most beautiful places to be. That's all I knew. So it's a very poor country. Unfortunately, a lot needs to be done, but there's a lot to appreciate about the country as well.
Definitely, yeah. Mm-hmm. That's very interesting. Yeah, because like you said, what we hear, in the media about Haiti, you always hear about the crime and the corruption. And, unfortunately, as we all heard, there was a catastrophic, earthquake that happened.
Yes.
Right. Which led to, various outbreaks, cholera, et cetera. But the fact that you had such a good experience growing up in Haiti is great. So thanks for sharing that.
Oh, I'm blessed. I was very blessed. It's up to this day, I have this romantic nostalgia about Haiti, thinking one day I'll go back. Unfortunately, like everything you just mentioned is real. There's the majority of the people in Haiti are suffering, and corruption, political instability, crimes, and these days things are, unfortunately, this is the worst I've seen this country.
So Jovi, you came to the U.S. like you said when you were 15. Where did you go to college? How did you get inspired to go into medicine? What was that spark for you?
Oh, Ted, I'm not sure if I ever shared that with you, Ted, but it's I think at the age of 13, I had already made up my mind that I was going to be a musician. Music is the thing that I love, playing with bands and everything. But of course, my parents disapproved of me being a musician, playing in nightclubs and doing all kind of stuff. That wasn't the life they had envisioned for me.
Sure.
So
But you're a fantastic bass player. We know that.
I'm all right, though. when I look at the real people who do that for a living, I get inspired, But no, music is something that I thought I was going to do, but my parents wouldn't let me do it. So I'm thinking, okay, fine, education, education, education. So I always thought, okay, I'll go to school, get my degree and give it to them and then let me do what I want to do. So that was always my plan. And came here, finished high school in America, and I was doing well in high school with respect to the sciences. And I knew I had to go to college to get my parents off my back. But exactly what I was going to study, I don't know. I was going to do music, but they wouldn't pay for me to just study music. I'm like, okay, fine, I can do something else. And then one of my biology teachers in high school actually told me, I planted the idea that, oh my God, you do so well in the sciences. You sure you don't want to do medicine? Because most people who do well in biology and, chemistry and stuff usually end up in medicine. So I was like, oh, really? Okay, I guess that could be an option. And then, to be honest with you, Ted, he planted that idea in my head as I was finishing my senior year in high school, and I went to Brandeis University in Boston, thinking that okay, I'll do the pre-med, do sciences, some kind of sciences in college. Initially, it was neuroscience. That I was like, oh, that sounds interesting. And then neuroscience turned into pre-med, and never looked back. And I don't know what happened to music at some point.
Well, I mean, like I said, you're a great bass player, Jovi. I mean, I've heard you play many times in Ghana at night. It's actually very relaxing and very decompressing to hear you play at night.
I appreciate that, Jeff. Thank you.
Sure. So you went to it sounds like you went to med school in Boston. Is that correct?
No, so I did college in Boston, and I ended up in Philadelphia at Temple University for med school.
Okay.
And from there, I decided to, instead of doing neurosurgery, decided to do general surgery there. I ended up at Penn State for general surgery residency. And after Penn State, I came to University of Chicago and North Shore for endocrine surgery, where I further specialize in.
And that's fellowship, correct?
That was for fellowship, yes.
Great. So kind of transitioning, talking about the main meat of the talk here. As I stated, Jovi specializes in endocrine surgery as well as oncologic surgery. So Jovi, I'm sure as an endocrine surgeon, you deal with a lot of thyroid nodules and goiters.
Yes, indeed. That's a significant part of my practice. I see, as you know, these days, everybody who goes to the ER gets a CAT scan or an ultrasound for some reason. So we are picking up a lot of lesions that otherwise would have been unnoticed. So as a result, a lot of lesions that I see in my office, are people were referred incidental findings or something that a primary care physician might have picked up on routine exam or physical exam. And so, yes, thyroid nodules, it's very common in the population, mostly in females, too, I would say.
Sure. So, Jovi, tell the audience, how would you work up a patient for a thyroid nodule or a goiter?
So, most of the patients I see in clinic, if the patient is coming from me specifically for a nodule that was discovered on either by physical exam or an ultrasound or something that was done, the first thing I look at the patient in general. You get a full history, see what's going on. On physical exam, you look at the nodule and see how does it feel. Most nodules feel pretty soft, mobile, that usually are benign. Occasionally, you get some signs that, okay, it's hard, it's stuck, and you see some enlarged lymph nodes in the neck. Well, I do see some of those occasionally, but the majority of the nodules that we see on physical exam look pretty benign. And I'll start with that and get some blood work to see because some nodules can be overactive. Some are non-functional at all. They're not when I say overactive, I'm sorry. I mean, they're producing hormones that can affect your metabolism. But then you check the blood work to see what the thyroid level is, if that is normal. And then, of course, we also always get an ultrasound to see the characteristics of the nodule. If it appears benign, it's not too large, then those we observe. I'll bring the patient back every year for 3 years to make sure that the nodule is staying stable. It's not changing. Check the ultrasound. But if we get the ultrasound, it looks suspicious for, calcification, increased blood flow. It looks irregular. Then we usually, right in the office, I'll put a needle in the nodule and then get a sample of it and get it tested, what we call a fine needle aspiration, and then send it to the lab and have it evaluated and see what's going on. And most of the time it turns out to be benign, but occasionally it turns out to be cancerous. And then if it's cancer, then we go down a whole different algorithm and go from there.
Okay, that leads to my next question, Jovi. Mm-hmm. What are the different types of thyroid cancers?
Quite a few. Well, there are 4 main types, and it depends on how you are trained. Some people will even say 5. Different types of thyroid cancer. Oh, well, let me just say, when you look at thyroid cancer in America, it's I believe at last statistics I read, I was at the Endocrine Society, I think last year, was number 8th leading cause of death in America. So it's at the bottom, top 10, but it's significant enough. So I think it's about 60,000 people a year get diagnosed with thyroid cancer in America, compared to 250, 240,000 in breast cancer. I think colon cancer is the second one. So thyroid cancer is at least, it's significant enough, over 60,000 people, that's significant, but it's not the leading cause, as you probably know. But as far as the types of thyroid cancer, the most common type of thyroid cancer is papillary type, usually benign, most people, And I always say that to my patients. If I were to choose which type of cancer I have to have, I hope I won't have to have any, but I would choose papillary, at least the most common type of papillary thyroid cancer, which is, pretty benign. Not benign, it's indolent. People survive, their survival rate for that is pretty good. So that's the most common. Fortunately, that's the most common type of breast cancer. I think that's thyroid cancer. That's over 90%, I would say. There's also follicular type. Follicular type, sometimes people can call it hurdle cell and put that in a different category. So if you do look at papillary type of thyroid cancer, follicular thyroid cancer, hurdle cell, medullary thyroid cancer, and anaplastic. So that's about five different types. Yeah, but of course you don't want to have anaplastic. That's the worst form. Luckily, we don't see it very often, but it can be very aggressive, and it's as bad as some of the other types of cancers out there that can be fatal, I would say.
Sure. And what are some of the risk factors for thyroid cancer?
One thing we know for sure, if you've been exposed to radiation. When I say radiation, people have been treated for external beam radiation, right? That puts you at high risk for, let's say you had Hodgkin's lymphoma, or you had some kind of head cancer, neck cancer elsewhere, and then your thyroid got exposed to the radiation. That's a significant risk factors for thyroid cancer. If you've been exposed to iodine, I-31 from an bomb-making capacities, let's say people who were in Chernobyl, or you were in areas where there were, atomic bombs being developed, and you are exposed to that, then this is another significant risk factor for thyroid cancer that is proven and known. As far as other risk factors people talk more common, we know if you're a woman, you're 3 times likely to have thyroid cancer than a man, so that's considered a risk factor. There's some genetic form of thyroid cancer as well. If you had multiple endocrine neoplasia, which is a form where some patients have a genetic abnormality, it's the red proto-oncogene that put you at risk for multiple endocrine glands in your body, and namely the thyroid, parathyroid, and pituitary. So these patients have a high risk for developing thyroid cancer. Actually, that's the medullary type. You were asking me what the different types of thyroid cancer that you have. So medullary type of thyroid cancer is usually, I think, 25 to 35% of these patients have. I think there's a familial component to it. People also talk about obesity sometimes. It's as we know, obesity is bad for everything. It's a risk factor. But the other thing that it's low iodine in the diet. Actually, outside of America, patients who have an increased risk of thyroid cancer in populations where there's low iodine. So that's something to consider. What else off the top of my head? These are the main risk factors for thyroid cancer, really.
Sure. Now, talking about risk factors, In your experience in the last few years, Jovi, have you seen an uptick in cases with COVID vaccine?
No, I haven't. In fact, there was a study that came out recently, and that was discussed at my last National Endocrine Association of Surgeons. It's the most common reasons thyroid surgeries is being done these days. It's for non-cancerous indication. Either uncontrolled Graves' disease, large goiter with compressive symptoms. So
Right.
no, and as far as I know, and with the studies that have come out, I haven't seen any relationship between COVID and thyroid cancer.
Okay. Thanks for clarifying that. What are the different treatment modalities, Jovi, for thyroid cancer?
So I'm laughing because as a surgeon, you're always biased, right? If you have a nail or a hammer, everything looks like a nail. But I think I would be pretty use scientific evidence-based medicine. The primary treatment for thyroid cancer is surgery. Okay. It's if it's cancerous, it has to come out, and you actually physically have to go in, make an incision through the neck, put the patient to sleep, of course, and remove the entire thyroid. Well, not depending on the size of the lesion. Actually, let me take this back. If it's a small lesion, less than 4 centimeters, it has been shown that it's safe to just remove the side where the cancer is. The thyroid has two lobes, left and right. It looks like a bow tie, and if it's certain size, you can just remove the other side. And if there are no nodules on the other side that look suspicious, you don't have to remove both thyroids. More often than not, we end up removing it, the entire lobe, entire thyroid, because there might be something else there. But surgery is a primary a form of treatment. The other, occasionally, after we remove the thyroid, us endocrine surgeons, if let's say the lesion had gone beyond the thyroid, or there were lymph nodes involved, or based on the size of it, we tend to believe occasionally you have microscopic thyroid cells that may be left behind that we cannot see with the naked eye. Under those circumstances, what we do, we not only do we remove the thyroid, but after surgery, we encourage patients to go ahead and have a radioactive iodine. It's a pill that they take, it goes into their system, and any leftover thyroid tissue in the neck absorbs that iodine that actually will kill those cells. So that's a second, it's more an adjunct treatment, not as the primary. So you wouldn't give somebody radioactive iodine as a primary treatment for thyroid cancer. There are occasions where the lesion is so involved in enlarged, it was touching, encroaching on the trachea or the structures in the neck. You feel like, there might be leftover disease and what we call positive margins. And if you see disease elsewhere in the neck, you try to remove the bulk of it. But if you can, external beam radiation can actually be used in certain cases to really kill the leftover cells. What else? There are some form of anaplastic thyroid cancer, that one of the forms we mentioned earlier, where you can use chemotherapy for that, because that's a very aggressive type. Even so, you do surgery, you do the radioactive iodine, and you do external beam radiation, and then some of these patients still end up with platinum-based chemotherapy, taxane, cisplatin, and we don't need to get into details, but these are extremely, extremely rare. But the primary treatment for thyroid cancer is surgery.
Okay. And what percentage of these patients would you say that in the future you have to go in again for a second surgery and maybe do, a little exploration and further dissection?
I would say less than 2%, so the cure rate. So if we look at the 5-year survival rate for, let's say, the most common type of thyroid cancer, which is a papillary type, that it's over 98%. In 5 years, 98 of these 98% of these patients do not have cancer. So only 2% may have a recurrence or persistent disease. So these are the patients you may end up going after and do additional treatment, additional surgery. Sometimes it's a full neck dissection, depending on where exactly the lesion is or has recurred. So, but that's what I was saying earlier. Thyroid cancer, if you have the most common form, is the best case. One of the probably least aggressive type of cancer to have, if you have to have one.
I see. Well, thanks for going over that, Jovi. Just a couple more questions for you. What was your experience like as a surgeon during the COVID peak?
Overwhelming, just like for everybody else, I would say. But more specifically, I would tell you that you're a critical care doc, so you understand this completely. It's a lot of these patients, unfortunately, we couldn't trick, because the lung disease was so advanced, the lung was fibrotic, their peak airway pressure was too high. So when somebody is on a ventilator, for people who I'm speaking very technically, very technical. What is it? We call shop. We're talking shop here. I'm assuming our audience is mostly medical, but for those of us, of the listeners who are not medical, so if you have COVID, you cannot breathe, and we put you on a ventilator. When it's time to remove you, we want to remove you from the ventilator as soon as it is safe to do. But once you go on past 7-10 days on the ventilator, we're concerned about your vocal cord, the rest of your throat, and so we prefer to remove the tube and then the tube via your mouth and put it through your neck. That way it allows us to do better treatment. The treatment of your lungs is better that way. Unfortunately, we had to keep a lot of people on the breathing machine for so long because they were not safe to take them to the operating room to remove the tube and put a tracheostomy through their throat. And unfortunately, we were losing a lot of these patients right there in the ICU to the point where they fail in medical management, they're not improving, and there's nothing else you could do. So from my standpoint, as a surgeon, because I do a lot of the trachs in the hospital, and these patients, we couldn't even get them off. The oxygen level requirement and their airway, the pressure in their lungs was so high that we didn't have a window to actually perform a trach where we can actually keep them alive a little bit longer. So, and when they come in, they say, okay, they have COVID, you think, okay, they're gonna end up on the long run on a trach. Can we be aggressive from the get go? But we couldn't determine who was who. So it was, we had to learn as we go. And unfortunately, we did lose a lot of patients that there's not much else we just could do.
Yeah, you're absolutely right. It brings back a lot of
bad
memories.
Imagine. I'm sorry.
No, it was like you said, it was sort of the Wild Wild West. It was a novel virus. And I actually remember in my hospital that most of the elective cases were canceled and the OR was essentially closed. Was that your experience?
Yes. So we did that the first 2 weeks. And after that, as you know, a significant portion of my practice is cancer patients. Then if somebody has breast cancer, colon cancer, like, okay, oh my God, I know at some point we have to address this, we don't know how long this thing goes. So we had made the decision and said, okay, we don't consider cancer as elective and it needs to be done. We're going to take the risk. So this is where we are using PPEs and everything we could, and even paper mask actually to do those surgeries because they needed to be done. So yes, we did close our hospital, but one thing I think we did right was to keep the cancer patients going. So you can imagine everything else.
Yeah. All right, Jovi. What's the biggest surprise you've had in the last few months or years in this field?
Surprised. You know what? It's how COVID. Personally, I would say how COVID has changed our practice to some extent. Right. Usually, when you do a total thyroidectomy, for instance, since we're talking about cancer, right, and thyroid, and it used to be you keep these patients in the hospital and make sure But with COVID, we were trying to just do the surgeries and not keep the patients in the hospital. That way, they were not exposed. But if you really needed to get it done, so we ended up doing something that I've been looking at for a little while, for many years, that we didn't think we could because But people would have their thyroid surgeries and entire thyroid remove and get discharged the same day, and they did okay. So now it's funny. Now we're not dealing with the pandemic again as badly as we were before. Now, okay, we just kept that going. So I think that's kind of a surprise that before I would used to do that and people would look at you like, whoa, 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 whoa. But now it's becoming acceptable, or eventually it may even be the norm. So that's off the top of my head. That's how I would say. That's what I can think of.
Right. Yeah. I think COVID has changed the way we practiced in many ways.
Very much so. Everywhere too. I'm sure there are so
Right.
many other doctors who can relate to in different ways.
That's right. What are some of the things that excite you the most right now in this specialty?
So robotic surgery, I would say, and now we're getting to a point where some institutions are pushing and have the resources and I would say, I don't want to say clairvoyance, but people are pushing for what we call transoral thyroidectomy, where to avoid a scar in the neck, then now we're going through the inside the mouth, underneath your tongue, make an incision and follow a pathway there that leads us to the thyroid in your neck. And then go in there,
Mm.
remove it, and then close that also. And people wouldn't, so I guess we pretty much could call this scarless surgery. I think it's pretty cool that we could do that. A couple of years, when I was training, I think it was 10 years ago or so, we started doing this robotically, and the complications were a little bit more than the standard way of doing it. It looks like it was a little bit cumbersome to go through all this because we were going through the axilla, make the incision through the armpit, and go all the way through the neck. And all this to avoid a scar because, some scars can be somewhat not so sightly. That didn't really, so far, hasn't really panned out well. Then now people are looking for other ways to do this and make it better, and I think in the upcoming years, the new generation of surgeons may be doing this from the inside and without leaving any scar behind. So I think that would be good. That's pretty exciting to me, at least.
That's outstanding. Yeah, thank you for sharing that. So, in addition, like I mentioned earlier, Jovi is a excellent surgeon and a phenomenal basketball player, but he also gives his time to others that need it. Jovi, tell us about your personal experience with Anidaso Health.
Anidaso means, first of all, I think that's how we met, Ted, So Anidaso means a lot for me, not only because of what we do there, but also it has part of being a part of Anidaso is being part of a family that Ted, you have created. And then you've been a great friend to me. You're the type of person I could call if there's any question and concern, everything. So, and I thank you for your friendship. You may not realize that but it is, we don't find people who very often who understand the meaning of friendship and stuff. And to find that in you, my friend, that means a lot. But Anidaso to me, in addition to this, Anidaso is that I come from a third world country, and for you, Ted, to, organize this and take us, across the world to help people who are not as fortunate means a lot to me. But before I joined Anidaso, I was doing mission work in Haiti, but it wasn't as organized as you have it and as Anidaso is. So once I met you, Ted, and you told me Mark Kevin told me what you were doing in Africa, and I'm like, oh my God, I would love to be part of this. And you guys gave me that opportunity. And so when we go to Africa, there's a lot of similarities culturally, what you see in Africa and what you see in Haiti. Some countries may be doing better than others, but, I feel like I'm at home when I'm in Ghana. And not to be able to provide my help, So I'll tell you this, Ted. So the way I see it, and why Anidaso means so much to me is that I'm in Chicago, right? Where some leading universities are in the city, okay? 4 or 5 top notch, so patients are out here, have access to health, have choices, you don't need, there are multiple endocrine surgeons, all the, well established, so people can have that. Their thyroid cancer taken care of, their, Graves' disease and everything else taken care of. But the places we go to, Africa and Ghana, these patients don't have access to that, So there are times I feel like my help is more needed in Ghana than it is in America, to be honest with you, So having Anidaso to allow me to provide care to people who otherwise wouldn't get it, it makes my work a little bit more meaningful to me, going to Haiti, in places where people, So no, Anidaso is my baby, and thanks to you for giving me that opportunity and us that opportunity to, you have the view, the vision to make it happen, and then bringing people from different specialties to go there. So it's, I can't thank you enough, Ted.
Oh, thanks, Jovi. I mean, we are certainly blessed to have you as part of the team and also a great friend. I can't tell you how many lives Dr. Cherenfant has touched and changed personally in Ghana. And I am just in awe, Jovi, at some of the cases that you are willing to tackle and take on. I mean, some of these goiters, when you look at these women, it looks like they've got anacondas in their throat.
Yes.
I mean, it's just massive goiters. And the type of surgery that you're able to provide them just in this low resource type of setting, you know, without the fancy CT scanners, you know, the fancy ultrasound equipment. It just amazes me. And like I said, I'm in awe that you're even willing to consider helping these people. So thank you.
No, but I cannot take all the credit though, because if you don't have a good anesthesia team, as a surgeon, that's so. Yes, I'm able to do that. It's because we have, very skillful anesthesiologists. We can we don't have this, we don't have that, we only have this. The trachea may be deviated. We have all that. You know what? We got this. So the anesthesiologists will come with us. And I'm nothing without them. So let's just...
definitely, yeah. It's the entire team, of course.
When you take Brian and Michelle, Denise, all the anesthesiologists who have come, and everybody else. So it's amazing that these people are like using their skill set in different ways to do this. So no, thanks to them too. Because if they say no, there's nothing we can do. If they say yes, we at their mercy. So
that's right.
It is amazing what they can do with very little resources, as you mentioned.
That's right. Fantastic, Jovi. So one last question. Going back to your bass guitar playing skills, is that how you mainly decompress when you're not in the OR?
Well, you know what? I love music. I took it professionally at one point, and I still, to me, my day is not complete if I don't play the bass, Jeff. It's everything I have to do. I have a family that I love dearly. I have to give them time. I have medicine, my workout. You can be in the OR all day, get home, put my babies to sleep, spend some time with my wife. Then even if I spend 10 minutes playing the bass, that's all I need. 5 minutes, it's a simple skill. So it's yes, that helps me stay focused and balanced, and also let me know that I'm not missing anything else. But I have many interests. I love sports. Playing basketball every Sunday morning. Try to run. Stay in shape. It keeps you going. Luckily for me, I guess I don't know what, I haven't been diagnosed formally, but I do suffer from insomnia because all I need is 3 to 4 hours of sleep and then I'm ready to go. So that cannot be healthy. But somehow I still manage to function. So that allows me, some people, if they don't get 8 hours of sleep, they can't function, or no, I haven't been like that,
Oh, so. I can attest to that. In Ghana, you're usually the last person to bed and then the first guy up in the morning. So
hopefully it doesn't come back to bite me as we get older. But so no, I mean, there's so much, medicine is big and stuff, but there's a lot in life we have to enjoy each other's company, enjoy music, enjoy things that, it keeps you balanced sometimes, even after a tough case in a hospital at work, you get a thyroid case that just, oh my God, huge, stuck to the trachea and everything. And, you feel accomplished, but you go home, you decompress and thinking about it, and you pick up your bass and do something, that's fun and satisfying. So I don't know, we all have that, right? I'm sure. Yeah.
Yeah. Well, listen, you're very inspiring, Jovi. Keep doing what you're doing. And I look forward to, working with you in Ghana. And I want to thank you again for your time and being a guest on MD Roundtable.
Ted, the feelings are mutual. But one day what I'd like to do is change the table, really turn the table around it completely, where I'm actually the one interviewing you, because you have so much, your life story, everything you've done. I'd like to sit down with you and then have the, if you allow me, but I have to learn how to be a podcaster first. Okay. When I'm ready, I'll come back and then I'll interview you one day.
All right. Once again, sounds Ted, good. One day.
Thanks for everything, my friend.
My pleasure. Thanks again, Jovi. Have a great day.
Take care. Bye.
Bye. Folks, if you enjoyed that episode, don't forget to leave a review of the MD Roundtable podcast on Apple iTunes, and please don't forget to subscribe. Stay tuned for our next podcast coming to you soon. Thanks for joining me again and have a great day.